IAP and my friend Dr. Vijay Kumar, Dr. Jishin, and the stalwarts of today, Dr. Riaz and Dr. Rajesh. I welcome all of you. Today, it's a very important topic that these two stalwarts are discussing, that is precocious puberty. And every time we read, we forget. And but it is very important for exam-going students to learn the points. And this will be one of the cases that will be kept in as a short case or for DNB exams as a spotter or for case. So we have with us two persons who have been dealing with endocrinology for a very long time. Dr. Riaz has been doing and did his fellowship from Bangalore, and Dr. Rajesh has been running the endocrinology clinic with our dear past president, Dr. Vijay Kumar, for so many years. And the interesting fact is that I think every, even in Trivandrum, where Riaz is conducting his OP, even though he's stationed in now in Idiki, he goes there and conducts the OP on Friday. And it shows his interest in pediatric endocrinology and this will to teach. So thank you, Dr. Riaz and Dr. Dr. Rajesh for taking this initiative in a very short time, because I told them only 2 days before, and now they have come up with a very interesting case, and it is being presented by none other than Dr. Akshaya, who is one of our brilliant postgraduate students, as Dr. Vijay Kumar would vouch for it. And so invite all the participants, senior pediatricians who are assembled here. And if I have missed any person, I welcome everyone to this interesting topic and discussions that you would relish in this next 1 to 1.5 hours. So welcome everyone in one sentence. Thank you.
Thank you, Ajit sir. Now I request the master brain behind this program, our dear President, IAP Kerala, Professor Dr. Jose O. for his address.
Thank you, Dr. Krishna Mohan. Thank you, the President of IAP Kozhikode, Dr. Raj Kumar sir, and Professor Vijay Kumar sir, immediate past President, the State Convener of the program, Dr. Shanwas sir. Today, the faculty, Dr. Riaz, Dr. Rajesh, and the key persons, our PG teaching program, Dr. Purushottam sir, Dr. Dali madam, and all the senior members or faculty of the AP and all my dear postgraduate students. As you know, we are every Thursday, we are assembled here to learn some of the common issues in PG teaching programs. I think everybody will be benefited, even the IAPians or the faculty has benefited from the discussion in every Thursday at 7:30 p.m. Our state convener, Dr. Shanwas, have taken all initiative to conduct the program regularly without any interruptions. And we are last 1 year, we are conducting every Thursday without any interruption. We are conducting the program, and thank the Shanwas sir for all the arrangement. Again, I especially thanks IAP Kozhikode, Dr. Vishnu, Dr. Kumar sir, taken all the steps to arrange a common issues. As you know, precocious puberty is one of the difficult topic, because once you discuss the topic, we learn easily, but one day within hours we forgot everything regarding that approach and everything. So again, refreshing our knowledge to common issues, that is very important. So none other than Dr. Riaz is there, Dr. Rajesh is there, and with Akshaya is from the MCH Kottayam, Kozhikode is going to present the topic. I think we will have a good, fruitful discussion on this aspect of endocrinology. I wish you all the best program. Again, I congratulate Dr. Vishnu for arranging all the arrangement. Jai Hind, Jai AP.
Thank you, Joe sir. Now I request our dear immediate past President of IAP Kerala and HOD of Government Medical College Kozhikode, Professor Dr. Vijay Kumar sir, join in the field of pediatric endocrinology to say a couple of words.
Respected President, IAP, Dr. Joe, Dr. Ajit, Dr. Vishnu, Dr. Shanawaz, Purushottam sir, Riaz and Rajesh. I think this is I think this is going to be a very good academic feast. And one favorite topic of pediatric endocrinology is precocious puberty. As Dr. Jose said, whenever, even if you discuss 100 times, there will be confusion always. And Dr. Akshaya has made that topic very simple, and her I have seen her PowerPoint. It is very good. And so definitely we will get a good output from this discussion. And thank you all. And all the best, Akshaya. He is one of our favorite PG student. Actually, she is from Andhra Pradesh. Over to Dr. Akshaya. All the best.
Thank you, Vijaykumar sir. Now I request the chairperson of this program, who has been there throughout for maintaining the continuation of this program every week, dear Shanavas sir, to tell a few words.
So very good evening to all, respected IAP State President, Jose sir, past President Vijaykumar sir, and senior faculties, including Virashothaman sir. So I'm very happy to be with you with this program, especially with Calicut. So every fourth Thursday of every month, we are very well prepared with the case, and there is no problem for case. Whenever I discuss to Dr. Vishnu, there is no case, he will immediately accept and present. So there is no problem. This time also it's like that. Thank you, Vishnu, and the Calicut team for this. And today already it is discussed. This is a very important case. I express all the best for this case. Thank you. Thank you very much.
Thank you, Shanavas sir. We have two eminent faculty, as told by Jose sir, additional professor of Calicut Medical College, Professor Dr. T.V. Rajesh, who runs the endocrinology clinic at IMCH Calicut, and additional professor at Government Medical College, Idiki, Professor Dr. Riaz I, again, one of the vibrant and most noteworthy active IAPs from IAP Kerala. And dear Riaz sir, again, expert in the field of pediatric endocrinology, to mentor the sessions today, and Dr. Akshaya, who is a junior resident at IMCH Calicut. Over to Riaz sir and Rajesh sir to take over. Riaz sir and Rajesh sir, please take over.
Thank you. Thank you, Vishnu. And at the outset, I express my sincere gratitude to especially my dear teachers. Many of those who are here are my teachers only. And I think Jose sir has devised a very, very important idea of this PG teaching program, and have given the responsibility to a very passionate teacher, that is Shanavas sir, and everyone is following it up. And thanks to everyone. And without wasting much time, I think we can go to the case. Rajesh, if you want to say something.
Yes.
Before.
Okay. First of all, thank you, Vishnu and Ajit sir, and all my teachers, Ajit sir, Vijaykumar sir, and Jose sir, and all the other IAPians for giving me this opportunity. Precocious puberty, important topic for exam as well as in the practical management. So this is very important topic, and I hope Akshaya will present in the case. In between, some help I will add to the case. Riaz sir will discuss the case. Over to Akshaya.
Good evening, everyone. This is Akshaya from second year resident from Calicut Medical College. Today, I'm going to present a case related to puberty. A 6-month-old girl by name Neha, coming from Punnamangalam, Kozhikode. Informant mother presented with complaints of bilateral breast enlargement for last 2 to 3 months. Apparently normal child till 6.5 years, She presented with 2-month history of painful sensation of both the breasts, which the mother noticed as increased pain while bathing. No discharge from nipple, no redness or no color change, and there was no history of trauma. Child was shown in nearby health center in view of pain and doubtful enlargement of the breast. Child received a course of oral antibiotic and analgesics for 5 days, and as the symptoms were persistent, she was referred to IMCH for further evaluation. With these complaints, child was referred to IMCH. Initially, parents were told that the breast size is increased for age and were asked to take X-ray of the hand, which showed increased bone age. That was explained to the mother. Hormonal tests were done, which were told to be abnormal. An ultrasound of the abdomen and pelvis was taken. And the parents were told that there is need of monthly or 3-monthly injection. Currently, the child is taking monthly injection and is found to have no further increase in breast size and no further pubertal progression. No axillary hair and no pubic hair. There was no history of pubic hair or axillary hair noticed by mother. There was no history of bleeding per vagina. No history of sudden increase in height noticed by mother. There was no history of headache. No history of vision problems. There was no history of seizures. No history of trauma. No history of rapid weight gain, easy fatigability, and chronic constipation. There was no history of change in voice. No history of acne. No history of deformities of the limbs, or no hyperpigmented patches. No hyperpigmented spots. Past history. There was no history of CNS infections in the past.
One minute, Akshya. I think there are so many points here, so we can discuss, otherwise we will miss all this. So my first question is, this is a girl child, and the girl is having bilateral breast enlargement. Okay, so why you are thinking this is abnormal?
This can be normal also, but it should be it can present precocious puberty can present initially as breast enlargement. So it should be evaluated.
No. 1 minute. The question is, see, the appearance of breast in a girl is normal. Okay, so why is this abnormal in this particular child?
It's present in a 6-month-old girl.
So when should it happen normally?
Normally, it should happen after 8 years of age.
Okay, very good. So usually in girls, the first sign of puberty, that is thelarchy, should appear after 8 years of age. Okay, that is the abnormality. Like that, can you say in a boy at what time the first change of puberty should happen?
After 9 years.
After 9 years. So any change which is happening before 9 years, we should be alerted. That is clear, no? Okay. And also tell me what is the upper age limit. This is about puberty happening early. So when should one worry if no sign of puberty is happening in a boy as well as a girl?
Secondary sexual characters till 13 years of age in case of girl, and not attaining menarche till 16 years.
Okay, so many textbooks say 15 years. Okay, that is okay. And for boys?
For boys, 14 years.
Okay, for boys it is 14 years. Okay. And now can you tell me which is the what is the normal march of events? That is the changes which happen during puberty in a girl. In a girl.
Sequence of pubertal changes in girls is first is thelarchy, followed by pubarchy, then followed by increase in the growth spurt, height, and then followed by menarche. Hello. Is the voice audible?
There is a small. Usually in girls, the growth spurt can also occur a little early. Little early, means even with that, we can even start with the second stage of breast development. That is even with B2, B3. B2, B3, you have the what you call the growth spurt starting. And for the boy, it is, as you told, it will be late, like into stage 3, 4, like that, it will be happening. Okay. And that is why in school and all, when we are in a mixed school, sometimes we ourselves wonder, all the girls are growing in the same class, but the boys remaining smaller. Okay. Can you say what is the physiology behind that, the growth spurt happening in the girl first and boy later? No, it is not very something very difficult. Which is the hormone which is driving the growth spurt?
Estrogen.
Yes, it is estrogen. So, who produces estrogen first?
Girls.
The girl produces. When the pubertal changes happen, when the march of events happen, the first thing the ovary produces is estrogen. Okay. For the boy to produce estrogen, from where does the estrogen comes? In the boy.
From peripheral conversion of testosterone to estrogen from adrenals and from adrenals.
Yes, and from adrenal. So most of the estrogen is by peripheral conversion of testosterone. For that, there should be a definite amount, a significant amount of testosterone to get secreted. That is why it happens late in the boy. Okay. So now coming to the your history of presenting illness. There is the mother is complaining of some pain while bathing. So if this child was around 9.5 years and the mother is bringing the child to you with complaint of pain while touching, what will you say?
If it is 9-year-old girl, growing, breast is developing. So pain can be normal.
There can be some awareness which is normal. And another thing is sometimes parents.
Hello.
Okay. Sometimes some parents bring children and say that only one breast is size is more and the other is not developing like that. What about that? How will you counsel that mother? Hello.
Sorry, sir. I don't.
Okay. That is also normal, because when the development of breast is starting, usually maybe sometimes one breast will be a little bigger than the other, which that is also normal. So these are actually issues which will have a great concern for the child as well as the parents. So we should be able to counsel them regarding that. Okay. Then okay, we can go to the next slide. I think there are some negative points and positive. Yes.
Next
Okay.
slide.
Right. So there is you have written there is no pubic hair or axillary hair noticed by the mother. How does this history becomes important in this case?
Because it helps in assessing the stage of puberty, whether the child has
and that is one for assessing the stage of that. That means this is a early puberty. The puberty has not progressed into, okay, like that. What else this can tell you? If this was a for example 1.5 to 2-year-old child coming with some breast enlargement, it is there for some time and you are following up. So what is the other thing which you will consider? Do you know any type of
Agree.
normal variants of puberty like that?
With no pubic hair or axillary hair.
Yes.
Yes.
Ah.
There is
Yes.
breast is there,
Ah.
and it is staying like that. We are following up the child every 3 to 6 months, and for the next 2-3 years, the breast is still there. It's not increasing, and there is no other secondary sexual characters developing. What is that?
It's usually seen in 2 to 3 year and 2 to 4 years and 6-year-old girls. This I think this is normal.
This
What will-
is a
The condition
we
is
should
known
say
as sir,
known as
condition is
yes,
known as
known
isolate.
very good, correct.
Ah.
You are right.
Isolated thelar.
Isolated premature thelarchy.
Thelarchy.
Premature because it is happening early. Okay. So it is called isolated premature thelarchy. That is again a concern with which parents will bring children to you, where there is some enlargement of the breast, but it is not progressing. And there is not much of height acceleration. If you take a bone age, which will be normal, and other secondary sexual characters are not developing. Okay. So we will complete the discussion on that. How will you counsel such a parent?
Counsel. As such, this is normal. Will keep under follow up.
Very good, very good. We will tell that, but follow-up is needed, and report back after 3 months or 6 months as you wish, and tell them to report immediately if
Any pubic hair or axillary hair, if
very good,
any
very good.
bleeding.
Any other secondary sexual characters are appearing, you have to bring the child back. Okay, very good. Okay. So you have written no bleeding per vagina. So can that happen without any appearance of axillary hair or pubic hair after breast bleeding? Can it happen?
After breast development.
Without the occurrence of any.
They can. In case of peripheral precocious puberty, in case of estrogen secreting tumors, it usually presents with thelarchy and menarche.
So the usual march of events, like the sequence of events which we described, like breast development followed by pubarchy, followed by menarche, happens only in a case of true precocious puberty or central precocious puberty or gonadotropin dependent precocious puberty. These are the 3 synonym terms. Okay. But in peripheral precocious puberty, what happens is after breast, the child can have some spotting, some bleeding, which occur because it is due to excess of estrogen from somewhere else. It is not from the proper this gonadotropin its estrogen axis. Okay. So why is it so? Why in peripheral precocious puberty no adrenarche or no pubic hair is coming up?
Pubic hair and axillary hair is dependent on the testosterone. It's like male from adrenal glands. It's secreted from adrenal glands in case of girl. So
yes. It is mainly it is a there is a step called adrenarche, isn't it? Adrenarche. Have you heard of that? Adrenarche. Okay. So in adrenarche, what happens is there is there is an increase in the adrenal androgens. There is no relation between this puberty axis or the gonadotropin or the hypothalamo-pituitary gonadal axis. So that is an independent axis. Only thing is there is a temporal relationship. Usually adrenarche happens around 7 to 8 years, and which is temporally related to our pubertal changes. So in a small child that may not happen at this time. Okay, that is why peripheral precocious puberty usually presents only with breast development as well as your bleeding. Okay. So the next thing is you have written, there is no history of sudden increase in height noticed by the mother.
Yellow.
So what does that? What does that mean? Hello.
Indicates, hello. It indicates
Ah.
growth spurt, like whether child had developed increase in the growth velocity recently. I mean, to stage the puberty itself. Hello.
Yes, you are right. You are. So this growth spurt actually tells us that the process is on. The because for that there should be some time also. There should be some because in your history it is told it is only 2 to 3 months. So there is not enough time for the growth spurt to happen. Okay, so that is it. Okay. Yes, in this context, have you heard of a term called gonadarchy? We have discussed the thilarchy, we have told adrenarchy. Is there anything called gonadarchy? Have you heard that term? Okay, gonadarchy means the growth of the ovaries and testes, and there is an increased sex steroid production, either testosterone or estrogen. So in that stage, you can see testicular enlargement as well as ovarian growth. Okay, it happens due to the activation of the gonads by the pituitary hormones, LH and FSH. So that's a term called gonadarchy. Pubarchy, you have told. Pubarchy is appearance of the pubic hair. Okay. And menarche, everyone knows it is the onset of menstruation. That is first cycle. Have you heard of something called a spermarchy? What is sperm? Spermarchy. What is spermarchy? Spermarchy is the development of sperm in the testicle and first ejaculation happening in boys, maybe at the summer stage of 4 also. That is spermarchy. There is such a term also. And one more term attached to this is mini puberty. Can you say anything about mini puberty? When does it happen? Okay, no problem. The mini puberty means the activation of the hypothalamo-pituitary gonadal axis, which happens during the infancy. We all know that this axis is active even during the fetal development. The development of the external genitalia, especially in boys, happens because of the same axis, which is active during the fetal development. So that axis go for a quiescence during the 3rd trimester and so, and then it gets activated, but not to an extent of actual puberty. During infancy, usually occurs during the first 2, 3, 4 months. So we may have noticed that some boys, especially this is more evident in boys, there is a small increase in size of the penis and all during that period. And then it goes for quiescence again to become active again at a later age. Okay, right. So you have written no history of headache and no history of visual problem, no history of seizures. Why?
Was any lesion near to hypothalamus and pituitary can produce can cause precocious puberty, and the structures are very near to the optic chiasma, so it can cause vision problems and headache.
Correct. A significant what you call a significant lesion or some what you call some tumor or anything can cause all this, isn't it? And which is the most common lesion associated with this kind of early development of puberty?
Hypothalamic hamartoma.
Hypothalamic hamatomas, and they present with a particular type of seizures also. What are those seizures called? Gelastic, uncontrollable laughing episodes and things like that. Okay. And any other syndrome which you know, which is associated with a lesion in the brain which produces precocious puberty? I'm sure you know that. You can just
intracranial lesion.
Yes, someone has answered.
My
In
Yes.
neurofibromatosis, isn't it? Neurofibromatosis, you can have tuberous sclerosis, you can have such lesions. Okay. Okay, so that all you can remember. Okay, yes. Then you have written no history of trauma. How does trauma?
CNS insult. Any history of CNS
Any
insult.
history of, yes, any history of CNS insult. In that case, other than trauma, what all you want to include there?
History of like IUGR, PNA,
No,
hypoglycemia,
trauma, like
trauma,
trauma, CNS
head
insult.
trauma.
CNS insult.
Head
Okay,
trauma.
okay, head trauma. That is head trauma. What you have written is head trauma. That I agree. Any other thing? Any infection, CNS infection during the neonatal period? Okay, neonatal meningitis, tuberculous meningitis, then hydrocephalus, then treatment for some condition like a
Radiotherapy.
surgery in brain, radiotherapy. Okay, so all those things are important. Okay. There is no history of rapid weight gain, easy fatigability, and chronic constipation. Why these points there?
Any features to look for any features of hypothyroidism because hypothyroidism.
So I have heard that hypothyroidism causes growth failure. So why are you worried about puberty? Because tell me.
It can cause precocious puberty because of the because of the activation of the TSH, and TSH is similar to so it can produce ovarian cysts and can produce estrogen and like that precocious puberty.
Yes, very good, very good. So can you name the condition if you know?
Van Wyck-Grumbach syndrome.
It is called Van Wyck-Grumbach syndrome. It is very important for the pediatrician to know about this because these children, actually, these children with hypothyroidism, mostly untreated, long-standing hypothyroidism, can present with the ovarian cyst. Okay, so most of the time, when a child is presenting with a large ovarian cyst, people will think about malignancy. Sometimes inadvertently they will be subjected to surgeries, ovariotomies, all those things. But this particular condition need only supplementation with thyroxine, and all this will disappear. All the signs of puberty will also disappear. Okay. What will be the clinical clue in this particular case where an untreated long-standing hypothyroidism presenting with a precocious puberty, mainly breast development or sometimes spotting per vagina? What will be the most
There will be
important clinical clue?
short
Very
stature,
good, very
delayed
good, very
bone.
good. Short stature. Because remember, this is the only condition in precocious puberty where there is short stature. Because all other conditions will produce only advancement of growth, only tall stature. Okay, very good. Then you have written no history of change in voice, no history of acne. Why?
To ask for any virilization symptoms like
What are you suspecting? What are you suspecting?
testosterone producing ovarian tumors.
Very good. The androgen producing ovarian tumors or even some adrenal tumors which also produce some amount of estrogen. In all those cases, there can be change in voice, history of acne, clitomegaly, all those things. Okay, right. No history of deformities of limbs, no hyperpigmented macules. Explain.
These McCune-Albert syndrome can present as precocious puberty. In McCune-Albert syndrome, there is increased FGF23 production. One of the component is fibrous dysplasia, so there is increased secretion of FGF23. which can cause loss of phosphorus through the kidney, can lead to hypophosphatemic rickets. So,
Okay. When you look at the what you call the limbs, do you know any syndrome where there is polydactyly or syndactyly along with precocious puberty?
Russell-Silver syndrome.
Russell-Silver is usually the child will have a triangular face with a relative microcephaly, intrauterine growth restriction, and the forehead will be prominent, and the child will be short, all those things. But limb, there can be some clinodactyly, but not polydactyly or syndactyly. So there is a condition called a Pallister-Hall syndrome. Pallister-Hall syndrome is actually associated with sometimes concomitant hypothalamic hamartoma, and they can have this polydactyly as well as precocious puberty. Okay. And what about Prader-Willi when we are discussing limb anomalies? What happens in Prader-Willi usually?
Delayed puberty.
Delayed puberty. But sometimes Prader-Willi can also be associated with the precocious puberty, because we know that Prader-Willi, the locus is in chromosome 15q11, isn't it? And there is another gene called MKRN3, which is associated with precocious puberty. So sometimes but the central precocious puberty can happen with your Prader-Willi also. Okay. Okay, right. Then next, okay, past history. Okay, no, I think all of them we have already discussed, isn't it? And regarding the drug usage, it is very important to ask the mother whether the mother is on some estrogen replacement patch or something, so that the child get exposed to that. And can any other medication, do you know any other medication or toxins which can cause, have you heard of endocrine disruptors? Okay, endocrine disruptors are actually which stimulates the production of estrogen. DDT is one of endocrine disruptors. DDT, we know we use as an insecticide. So there are some postulates which tell that the presence of endocrine disruptors in the in our environment is one of the reasons why we are getting so many cases of precocious puberty where we don't get any other cause. Okay. So in the history, I think most of the other history may not be very relevant in this case. So I want our teachers to add on if I have missed anything in the history. Hello? Hello?
Vijay Kumar sir.
Gemma sir. Sir is not. Purushottam sir undo.
Yes, a good history, both of you. About the concern by the general public regarding the intake of chicken, is there anything to do with that?
No, sir, there is no evidence, and also it is not scientifically standing also, because after cooking.
One thing, Akshaya, in the presentation, the long list of no's, you kept the list of no's at the end of this thing. So what I would have preferred in this case is, at that time of presentation of last 2 months, in a 6.5-year-old girl child, breast enlargement, there your thought process would have been added before the investigation. You just jump to the investigation part, and you this thing is come initially itself.
Sir, that slide was actually misplaced. Sir.
Okay, that is the thing. Clinically, when a girl child comes with a rapid enlargement of breast, how you will be thinking? There should be the usual list of the thought process, and even in that thought process, far-fetched negative things need not be there. A list of negative things like the no skin pigmentation, no this thing, no this thing, no this thing, that can be added later. That is the one thing. Otherwise, everything you have covered, the neonatal insults, drug intake, and the neurological problems, social field, everything is good. Yes, I think you can go ahead.
Thank you, sir. Thank you, sir. Vijay Kumar sir is there or not?
Yes. I'm
Seeing him.
here listening.
Sir, anything
No,
more,
no,
sir?
no. Oh, no, nothing.
Okay,
And
okay.
everything is discussed so far.
Okay. Next slide, please.
Antenatal history. She's the second child of non-consanguineous.
There is, if there is nothing significant, we will move on, please.
Yes, one point, not in this case, in any patient for the PGs, one very important thing is the pace at which the precocious puberty moves forward. In this case, everything is only 3. So in any other case, it's very important.
That we discussed. That we discussed, like if the breast is appearing and then it is staying for a long time without the appearance of other secondary sexual characters, without any height advancement, we can monitor the child without doing any further investigations, because that could be isolated premature thelarche. We discussed that, sir. We discussed. Next, please.
And antenatal history, she is the second child of non-consanguineous marriage, conceived spontaneously, confirmed pregnancy in second month.
Akshay, we can go to the next slide. It's okay.
Gestation.
So in this also, is there anything important regarding our case?
Preeclampsia, radiation exposure, fever with rash may lead to small for gestation baby. So that is one cause for
central. Okay. Next.
Natal history, it's a term baby, appropriate for gestation. Birth weight 2.7 kg, cried at birth, and breastfeeding initiated within an hour. There was no history of hypoglycemia, no history of seizures, no history of admission into ICU. Baby was able to feed well and was discharged on day 3.
Okay.
Development history, age appropriate milestones are achieved. She's studying 2nd standard. There is good scholastic performance. Diet history, exclusively breastfed till 6 months of age. Complementary feeding started after 6 months. Immediately, breastfeeding continued till 1.5 years. Receiving adequate calories and protein. There is only a deficit of 50 kilocalories.
Is it more? Is it more? No, there is no excess. So if you are supplying extra energy, will the puberty happen early? Because puberty is a high energy process, and
there might be a little early pubertal changes.
Actually, there are conflicting reports. So there were many postulates that if the child is having obesity, there can be early puberty. But that is true regarding thelarche. Thelarche may appear early, but the age of menarche between the normal weight children and obesity is the same. So that it is this hypothesis not proved. It was actually regarding the leptin, as there is more making of or more circulating leptin that can act on the hypothalamus, this kisspeptin area, and then you can have this. But the breast may appear early, but age of menarche is the same. And regarding boys, actually, the studies say that for overweight babies, for overweight boys, there is a increase in the early development. but for obesity, it is not there. So as a summary, actually, this weight hypothesis is not very much true. Okay, next.
Family history. There is no history of early pubertal changes in family members. No history of short stature in family members. Mother attained menarche at 13 years of age. There were regular cycles.
Is family history important?
Yes, it's important because some are genetically inherited. That is, like with MKRN3 mutation, and there are some mutations known to cause precocious puberty inherited in the family members. MKRN3 and DLK1.
So there
is,
are cases of siblings getting early puberty, and now with the advancement of the genetic testing, we know that this maternal imprinting of MKRN3 gene can cause early puberty. Okay, right. Next.
Immunization history, immunized up to age.
One question. Can such a condition happen in a boy also? This genetic condition, early puberty? It is actually that particular condition that, no, I'm not asking about MKRN3. I'm asking about precocious puberty in family where only boys are affected. That is, the father is affected, the son is affected, but girl is not. It is otherwise called a male-limited precocious puberty, familial male-limited precocious puberty. I think if any of the other pages.
In the pedigree chart, what is the 13 and 6 year and 6 months for the parent you labeled or by mistake?
So by mistake, sir.
That is a mistake, sir. That's a mistake.
Sorry.
An extra line. Okay. So any other postgraduates, you if want to answer, you can answer this question. There is a condition called testotoxicosis. Is that testotoxicosis, which is actually a gain of function mutation. Okay, where you have the excess action. So your gonads will also be a peripheral precocious puberty where you get a increased size of testis. So it happens only in what you call in males because it is a LH receptor mutation and it is specific to the males. It is called a male-limited precocious familial male-limited precocious puberty, otherwise called a testotoxicosis. Okay, right. Next.
History, immunized up to age. Last vaccine received at 5 years. No adverse events following immunization. BCG scar present. Socioeconomic history. Father studied till 10th standard. Working as carpenter. Belongs to below poverty. BPL card holder. Included under health scheme. Mother studied till BCom. Working as she's a homemaker. Belongs to lower.
Why socioeconomic history is important in this case?
Yeah, because if it is a precocious puberty, child needs hormonal injections which are very costly. So,
right. So it is very important to look at the socioeconomic history also. Okay. Okay. Next.
General examination. On examination, child is active, alert, moderately built, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, heart rate 98 per minute, blood pressure 90/60 mm of mercury, respiratory rate 24 per minute, head to toe examination, head appears normal in size and shape, no acne or hirsutism, no facial dysmorphism, no axillary hair and pubic hair noted, no capillary macules, no facial puffiness, no pretibial edema, no deformity of lips.
Okay. Can any facial dysmorphism and connection with this? Can you tell something?
Kabuki syndrome.
Specifically, okay. Kabuki syndrome, Cohen
Yes.
syndrome is there. Okay. Oh. And I told about Prader-Willi also sometimes. Okay. And the examination is important. We have written no cafe du macules, and we have already discussed regarding that. McCune-Albright syndrome. Okay. Also neurocutaneous, other neurocutaneous syndromes like neurofibromatosis and tuberous sclerosis. Okay. Next.
Yeah, you better avoid that moderately built in the general examination, because you're going to mention the growth part in detail, height, weight, and all. It's very important. So when you're measuring that, usually we won't be mentioning this one. Okay.
And I have heard examiners telling we should not comment about the build in a child, because the build is about the final height. That is what I have heard of. So usually we don't comment about the build. Okay. Next.
Weight at 6.5 years, observed weight was 23 kg. Expected was 20 kg.
You can show the growth chart and then explain.
6.5 years, the weight is 23 kg, corresponding to 75th centile. Height is of about 125 centimeter, corresponds to 98th centile. 98th centile. Head circumference normal.
Next. Where is the chart?
One point, why you
Where is the chart?
about
The chart.
mid-parental height also? When you explain the growth chart,
I'm
especially when the height of mid-parental child also, you just complete and go forward, I think.
Akshaya, please show the growth chart. That is better.
You have to explain the growth chart, then only we will understand. No?
Everybody will have 80, 75th centile and all. You have that growth chart.
Yes, it is seen, sir. It is seen. Because it is in the mobile, we have to just move it. Then
Okay.
only we will see. Okay. Can you explain?
Yes.
Weight for
Explain.
6.
Tell me.
Weight for 6.5 years, it's 23 kg. It is corresponding to the 75th centile.
Okay.
And the height is corresponding to the 98th centile.
And the mid-parental height is at?
Mid-parental height.
You have shown there in the third centile, I think.
No, it is not.
There is a line there. I'm seeing a line in the third centile.
No, do you remember, Akshaya? At what centile?
Okay.
It was
No,
between
actually
10th
there
and
is
25th centile.
okay, no problem.
Oh.
It is okay. So you can tell how it is, why it is important, and how it helps. Akshaya?
Hello. Is it audible?
Yes. You are audible.
Mother and father's height may be height, so it cannot be taken as abnormal. Increased height.
No. The question is if you have plotted the mid-parental height also, if the mid-parental height was also there, how it would have helped us in this case? It is very simple.
Whether it is increased height, whether it is abnormal or normal.
Yes, because for a child to have a 90th centile height can be normal also. Okay, so if the mid-parental centile is somewhere near the third centile or below that, or in the 10th centile, and now the child is in the 90th centile, that means
definitely
that
abnormal.
child is told for the age. Okay, told for the age and told for the genetic potential of the particular child. Okay, so mid-parental height also should be plotted, and that actually helps in our this thing. Okay, what else you would like to have in the growth chart?
Bone age.
No, in the growth chart. In the growth chart.
Growth velocity.
Very good, very good, very good. So growth velocity is the most important thing in this particular child. Okay. If we had a previous measurement, that is why the importance of maintaining growth charts for children. If we had a few previous measurements, and if we see that this child had climbed from 10th to 25th to 75th, 90th, like that, that gives us a very important idea that this is a progressive central precocious puberty and this child needs treatment even before doing any test. Okay, so growth velocity is also good. Next.
Breast examination. There is breast bud present. There is no elevation from the chest wall, and there is no.
One thing, we have been discussing about the short stature situation also with precocious puberty, hypothyroidism and the syndrome. Okay. The upper segment, lower segment ratio also, not in other cases. When you mention about the measurement part, routinely we will be talking all these things. Upper segment, lower segment ratio also for precocious puberty. This is one situation where that the point is relevant. Not in this case where the height is on the higher centile. The centile of the height is on the lower side. You need to mention about the upper segment, lower segment ratios. Not in this case.
Yes, sir. Yes, I think all cases of especially endocrine cases, it is always better to do the upper segment, lower segment also. So how will you measure the lower segment? Can you explain?
We have to take the upper segment and then subtract it from height. So
no, you have to take the lower segment and then subtract it from the height. You have to take the lower segment. How will you do that? How will you take the lower segment?
Ask the child to stand and upper end from symphysis pubis, yes, and the lower end of the tape.
Yes, palpate the
medial
upper border of the pubic bone, and then from there you can just measure till the floor while you are standing for getting the height. Okay, right. So this child is having B2. You have written, actually it should be after the breast, it should be the pubic hair. Okay, B2, pH 0. Do you want to correct that? Is it pH 0 or something else? SMR you have written B2, A0, pH 0. It should be pubic hair 1. No, there is no 0 in our standard stage. It is 1. It starts with 1. No, 1 means like a child. So breast stage 1 means only the nipple is projecting out and other chest is flat. Okay, breast stage 2 means the areola is prominent. Then stage 3 means some palpable breast tissue is there. Stage 4 means the areola and the nipple forms a secondary mount, and stage 5 means areola becomes a part of the breast and only the nipple projects out. That is stage 5. Okay, so there is no 0. So you can write B2 and pH 2. That is all. Okay, right. Next, and you have very well written pink dull vaginal mucosa present. Okay, so why this dull is important?
Shiny mucosa is seen in case of
this actually we can just ask the mother to separate the legs, and you can just shine a torch. There is no need to touch even. So you can usually see the vulva is bright red actually in children. And if there is some amount of estrogenization, then it will be little dull pink. And sometimes there can be some mucus also. That all indicates presence of estrogen. Okay, next.
Clitoris is normal. There is no clitoromegaly.
Okay.
Systemic examination, neurological examination, visual fields normal. Other cranial nerve examinations are normal. The tone is normal in all the limbs. Power 5/5 in all the limbs. Reflex is normal. Her abdomen soft, no hepatosplenomegaly, and no mass palpable. The cardiovascular examination S1 and S2 heard normally. There's no murmur. Respiratory system normal, vesicular breath sounds.
Okay. So in what you call in a 3-year-old girl, okay, so 2 to 3-year-old girl has come with some appearance of some pubic hair. Okay. And when you are palpating the abdomen, you are getting a mass. Okay. What will you think about?
Can be adrenal tumor.
Yes. So in such children, always we should be thinking about something very serious like an adrenal mass. So pubic hair which is appearing early, be it in a boy or girl, we should take it seriously. Okay. Next.
To summarize, a 6.5-year-old girl presented with bilateral breast pain and enlargement for 2 months. Initially consulted nearby hospital for the same, received oral antibiotics and analgesics for 5 days, and was referred to IMCH. On examination, thelarchy present corresponding to stage 2 of breast enlargement, no pubic hair, axillary hair, not yet attained menarche. Height corresponds to 90th centile. So my provisional diagnosis will be precocious puberty.
Can you qualify that precocious puberty with? I know that you are yet to do investigations, but clinically also we can say whether it is. Yes.
Clinically, thelarchy is present before the 8 years of age.
Okay.
So that is one point, and there is increased height.
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 Okay. So this could be this. You are not very sure it is a central precocious puberty. This could be a what you call a non-progressive, isolated premature thelarchy also. Okay, because we are not having the MBH also, so we are not very sure about the height acceleration, and mother has not noticed any height acceleration. Okay, send it.
Yes, one doubt regarding the external genitalia examination, apart from the pubarchy, the staging. What about, is there any standardization or scoring of the clitoromegaly assessment?
No, sir. Actually, in a isosexual precocious puberty, that is our central precocious puberty, gonadotropin dependent precocious puberty, there won't be any clitoromegaly. Clitoromegaly will occur only in the contrasexual precocious puberty, which is otherwise called it is always will be peripheral precocious puberty, usually it will be because of, in girls, usually the clitoromegaly happens because of CAH. Most of the time it will be undiagnosed CAH, some non-classical type or non-salt wasting type, which presents later. And in our normal gonadotropin dependent precocious puberty, there won't be any clitoromegaly at all. And for clitoromegaly, there is a staging called Prader staging, sir. That is there, but that is not in case of a precocious puberty. Clitoromegaly, if we take it as a separate case, we can. There are 5 Prader stages, and stage 1, from stage 0 to stage 5, where 5 is actually like a male genitalia, and 0 is like a female genitalia, and different stages. It depends upon the actually the size of the clitoris, and the girth also is taken into account, and also the fusion of the labia.
That's not in the case of precocious puberty. I thought that this was very clear about this. That's why I asked. Just like in a male, you are measuring with the orchidometer and structured penile length and all. Is there anything like that? Something to be measured, to be mentioned in the case specific? That's what my doubt about the head circumference part. what is its importance? Is there anything in the Macron-Albright syndrome at circumference that way? If there is the cafe spot, that way at circumference is important. Is it common Macron-Albright syndrome presenting and you're getting the bony changes of the skull changes and all?
Yes, sir. We have seen cases, not very common, because most of the cases with precocious puberty are actually idiopathic, and we are getting some mutations only, genetic mutations, not any lesion or anything. Most of them are idiopathic, especially in girls.
Okay.
One lipomastia and thelarchy differentiation.
Yes.
Yes.
It's a very important clinical question. Can Akshaya say, or otherwise we will answer? Akshaya?
Cord-like structure will be present only if it's a breast.
One thing, one is like you have to examine the child in the lying down position. Okay, and that should be supine, and then you approximate your fingers from the periphery towards the areola. And if it is a true breast tissue, you will be able to hold the tissue between your two fingers. If it is lipomastia, it will just slip through. And the textbook say this breast tissue has a Kyer-like consistency. Okay. Rajesh, anything more to add?
The genital examination also you can highlight how to examine.
Okay, you can carry on, Rajesh.
Like supine and how to examine, how maybe practically relevant
for the male child.
Both males.
Okay. For the male child, sometimes it will be very difficult to examine the testis and all. So what we can do is sometimes it will be helpful for the child to be in the squatting position. So we can palpate the scrotum and the testis in a better way. And we should always have an orchidometer with us. Yes. Because in the male, the precocious puberty, the classification, everything depends upon the size of the testis. So we cannot assume that this is this size. We should have a orchidometer. We should actually hold the testis, only the testis, not the scrotum. Hold the testis with two fingers, and then you have to compare it with the orchidometer, the beads in the orchidometer. And a size of dash ml of testis is indicative of puberty. How much, Akshaya?
Testicular size of more than 2.5 centimeter. Size volume more than 4 ml.
4 ml. Okay, so we are more familiar with the volume because it is difficult to measure the length of the testis and all. So you just, because we are just comparing with the bead. Okay, so there will be, the beads will be numbered as 1, 2, 3, 4, 5, 6, then 8, 10, like that it goes. Okay, so it is like a what you call a string of beads. I think most of you may have seen that. At least we should be familiar with it. For DNB OSCEs also, it can be kept as a OSCE station. You should be able to identify that. And also measuring the penile.
Yes, about the procedures, external genitalia, the stretched penile length measurement.
Yes, that I'm coming to. This measurement of stretched penile length is also very important, because this stretching doesn't means you are going to pull out the penis. Okay, so what you are going to do is you are actually, you have to press down at the dorsal part of the penis over the pubis. Okay, and above the pubic symphysis, you can press down so that the buried penis can come out. Most of the time, children who are brought to a pediatrician with complaint of small penis will not be having any micro penis, but a buried penis, because most of the time we see the child is obese, the child is overweight, but the parents are just looking at the penis and complaining about the small size of the penis only. So you have to press down and you have to palpate the pubic bone, and from there you have to measure. For that, you can either use a scale or you can use your own finger. I always use my finger only with our nails cut, because scale can be painful for the child. So you can press down using your finger, and then you measure your finger. That will be the size of the penis. And when you measure, the upper end should be the end of the glans and not the prepuce. At the end of the glans, you have to measure from the pubic bone. That is how you look at the stretched penile length.
Yes.
Okay. Can we move on? Next. Darli madam, Shano sir undo. എന്തെങ്കിലും questions add on ചെയ്യണമെങ്കിൽ ഡാർലി മാഡത്തിനെ കണ്ടില്ല.
ഒന്നുമില്ല.
Okay. Continue. Continuation. Okay.
X-ray of the left wrist with hand is taken. The bone age compared with atlas is corresponding to 10 years according to Grulipel bone age chart.
Okay.
So
What is
there
the other method? One is Grulipel atlas, and also we have
online methods by Tanner
Whitehouse. Tanner Whitehouse method, where we score each bone individually and then add it. Okay. Actually, there is the mobile app which is based on the Tanner Whitehouse method. It is called Bone Age. The name of the app is Bone Age. It costs around 1,000 rupees. And once you buy it, it is lifetime. Even if you change the phone, it will migrate to your new phone. Okay. And it actually gives you individual scores. You can just compare, and then we can add on and you get the actual. Because Grulipel atlas is the most useful one in the clinical practice, because it takes only a very less time. What we are doing is we are just comparing. We are just comparing the X-ray with the standard. And actually, we have to look at the carpal bones. We have to look at the epiphyses of the ulna, the radius, epiphyse of the first metacarpal, and epiphyse of all the phalanges. That is why we need to ask for a X-ray of the hand with wrist. Only wrist may not be sufficient. Okay. And the problem with the Grulipel is there is a lot of inter-observer variation. When one doctor is scoring it, it will be different from the other doctor. And we get an approximation of around 6 months only, sometimes 1 year. But for the Tanner Whitehouse, we can get 1 month interval scores. That is the importance of Tanner Whitehouse. Okay, but it will take some time. In a busy clinic, it may not be very easy. Next. So there is a bone age advancement also.
bone age.
So there is now you are having a child who is having early development of breast with advancement in height, significant advancement in bone age. Okay, what is significant advancement in bone age? How much advancement we can take as normal? Up to 1 year, we can take as normal. Even for the delay, if there is a delay of 1 year also, that can be normal. And regarding the delay, we should also remember, in a case of this, what you call this, constitutional delay in growth and puberty, the bone age delay will be to the tune of 2 to 3 years maximum. If you are seeing a child with a delay more than 3 years, that is always pathological. Then never think it is a constitutional delay. That is important. Okay. Okay, you can carry on.
USG abdomen taken. Right ovary is measuring about 22 into 12 mm. Left ovary 23 into 12 mm. There's no adnexal lesion. Uterus is anteverted, pear shaped, 4.3 into 2.3 into 1.3 centimeters. Endometrial thickness is about 4.6 mm.
Okay. So in any child with a precocious puberty, after the physical examination, then the born age, and the next step is getting an ultrasound done, especially in a girl child. Okay. And can you interpret this ultrasound findings for us?
The ovary size is normal. Uterus is pear-shaped, which is suggestive of pubertal changes. In
Okay.
case of
So normal in a child, the uterus will be
tubular
tubular shape, and the ratio of the corpus to the cervix will be 1:2. Corpus is 1 and the cervix is 2. Cervix is longer. Okay. What happens during the changes is the cervix will involute. Okay. And the corpus will enlarge. That is why from the tubular size it becomes a pear shape. Okay. And what about the endometrium?
Endometrium, more than 3 mm is
Yes, more than 3 mm is
abnormal.
significant. 3 mm is significant, and if you are getting more than 5, that means there is a imminent chance of bleeding can also occur. And a easy tip for the pediatrician to remember is we can have a 1, 2, 3 rule. That is ovary size more than 1, uterus size more than 2, and endometrial size more than 3. So 1, 2, 3. So this is suspicious of estrogen action. Okay, this is actually estrogen action. The estrogen acts on the breast and development of breast happens. Estrogen acts on the uterus. All these changes are happening. And whenever we ask for an ultrasound, always tell them what we want to know. Otherwise, the radiologist will tell us liver is normal, spleen is normal, pelvic organs are not seen. Okay, because most of the time when a child is sent for an ultrasound, they won't look at the uterus and the ovaries. So we have to write. We need to know what is the size of the uterus. We need to know what is the size of the ovary. Is there any follicle or cyst which are seen? And also look at the endometrial thickness. Like that, we have to give a proper request. Okay. Okay. Then about count and all we can leave alone. What about the thyroid function?
TSH 3.1 milli-international units per ml, free T4 0.97 nanogram per deciliter. It's normal.
Okay. Okay. 0.97. Actually, it was a little lower side, but okay. Right. Next.
FSH is 8 milli-international unit per ml and LH is 2.2 milli-international unit per ml. Estradiol is 90.2 picogram per milliliter.
Okay. Okay. Of all this, which is the most sensitive test? LH, FSH, estradiol, LH. LH is the most sensitive test. LH is actually a marker of puberty. LH is a marker of puberty, and FSH is a marker of gonadal reserve. Okay. So because FSH sometimes we use to identify children with the Turner syndrome. We may have to wait for a long to get a karyotype, but definitely after the pubertal age, their FSH will be increased. That tells us there is some gonadal dysgenesis which has happened. So LH is our most important thing, and initially the sensitivity of our tests were not very good. So we were taking a value of 1 international units per liter. Later, it has come down to 0.6 international units per liter basal LH for a diagnosis of precocious puberty. Now with the ultra-sensitive radioimmunoassay methods as well as monoclonal immunometric methods, they are telling a LH level of more than 0.3 international units per liter is actually indicative of puberty onset. Okay, so that is about LH. And regarding estradiol, it is good that we have got a higher value, but sometimes we may not get, because estradiol again is a pulsatile hormone. So sometimes to get the yield more, we ask them to do repeated values. Every 20 minutes, 3 values, then pool it and then do the estradiol assay. And also remember, this occurs only in picograms per ml. That means there can be, it's a very small quantity and laboratory errors can be more. Okay. So in this child, the LH is 2.2, is clearly indicative of a central precocious puberty or a gonadotropin dependent precocious puberty. And to make sure you have again done a stimulated LH also, which is high. What is the cutoff for stimulated LH? More than
5 milli international units per m.
more
than
than
five.
yes, more than 5 milli international units per ml is positive. Can you say something about testing LH basal as well as some precautions and how we do it?
Basal LH is done early morning.
Early
done
morning.
in the early morning.
Yes, that is very important. Early morning we have to do. And for stimulation?
Post 2 hours after the GnRH injection.
Yes, there are different protocols. People say 2 hour, 3 hour, and we can even take multiple values. We can do one at 2 hours and one at 3 hours, and we can get a peak value. If the peak value is more than 5, that indicates it is a central precocious puberty. And what is the agent which you use for stimulation?
GnRH agonist.
GnRH agonist. Commonly used is
Leuprolide.
Leuprolide. Triptorelin also is used, but most of the time we use leuprolide. Okay.
Yes,
So next.
regarding
Sir.
the ovary, if there is a size disparity between the two, you go for the peripheral. That is one question. About the other one, they just like the other endocrinological or problems in a precocious puberty, is there any sites other than this thing, adrenal and the hepatic also should be screened for the ectopic source? Is there anything like that?
Yes, sir. Like that is why we have this because this estrogen can come from different sites. One is ovary, and another one is adrenal. So other than these two, I don't think there is a source, but this can happen in cancers. Like there are some syndromes like Cowden syndrome. Cowden syndrome which is a cancer predisposing disease where there can be multiple hamartomas, and one hamartoma can be in the hypothalamus, so that it can cause what you call the central precocious puberty. But the source can be either the gonad or the adrenal. About other sources, I have not read. Vijay Kumar sir, is there any other source?
Because it can be from exogenous sources. Otherwise,
okay. Yes.
It is very rare. I have also not heard.
Okay.
What about the FSH-LH ratio? Is it important?
Yes, sir. Here, the LH is high. That itself indicates that there is a central precocious puberty. Sometimes FSH-LH ratio in premature thelarchy, FSH will be slightly elevated compared to LH. Usually, FSH will be more than LH in premature thelarchy. But in precocious puberty, the reverse will be there. LH will be higher than FSH. But here, even the unstimulated LH is very high.
Yes, sir. That is true. And Akshaya is there. Akshaya got logged out, I think. The presentation have gone out. Akshaya.
I'll call her.
Akshaya will join.
Okay.
Akshaya മുങ്ങിയോ റിയാസ്?
Sorry,
വന്നു.
അക്ഷയ ഭയങ്കരമായിട്ട് നല്ലപോലെ ബാറ്റ് ചെയ്തു അല്ലേ? ഭയങ്കര നല്ലതായിരുന്നു. ഇതിന്റെ MRI ചെയ്തോ അക്ഷയ? MRI ചെയ്തോ?
Actually, MRI is not indicated, but it is done.
Not indicated എന്നുള്ളതിന് ഒന്നുകൂടെ എക്സ്പ്ലെയിൻ ചെയ്യാം.
Usually in girls, it is idiopathic. So the recommendations are only less than 6 years, maybe can be done. If above 6 years, not recommended.
ഓക്കെ അതായത് നമുക്ക് ഗേൾസില് ഒരു MRI ചെയ്തിട്ട് നമുക്ക് എന്തെങ്കിലും കിട്ടാനുള്ള ചാൻസ് എത്രയാണ്? ഒരു കോഴ്സ് അതായത് ഇഡിയോപ്പതിക്ക് എത്രയാണ് പ്രിക്കോഷ്യസ് puberty in girls?
Exact number I don't know.
കുഴപ്പമില്ല, ഉദ്ദേശം പറഞ്ഞാൽ മതി. more than 80%. അപ്പം നമുക്ക് മിക്കവാറും കുഞ്ഞുങ്ങൾക്ക് ഒന്നും കാണത്തില്ല. പക്ഷേ it is recommended that before 6 years you should always do an MRI. Between 6 to 8 years the yield is very low. Yield is very low. So it is actually a individual. Hello.
Kelkam.
So it is an individual physician's decision to do an MRI in the age group between 6 and 8 because of our new culture of defensive practice and all. Sometimes we even do because we should not miss something like that. So that is about that. Okay. Now, how will you counsel this particular parent and what will you do or what will you advise?
If the child receives injections appropriately, child will have good.
No. You tell them why this need to be treated.
It is need. There is need to treat the child because otherwise the child will land up in short stature and there will be some emotional disturbances as well to the child because of early puberty.
Okay.
Like school going kids, so there will be peer pressure, like
there can be a very 6 years means the child will be in the first standard or so, isn't it? So a child in the first standard getting a breast development, menstrual bleed, everything will be, there is a societal problem also. So all these are the reasons by which we decide to treat. Okay. And also now there are studies which say that early menarche is associated with the increased risk for metabolic complications like obesity, insulin resistance, type 2 diabetes, and even ischemic heart disease, etc. As an adult. Okay. So there are some long-term issues also. Okay. So what treatment you will offer?
GnRH agonist.
So you told GnRH is the one which is stimulating all these, and you are asking them to take the same drug as treatment.
Continuous GnRH hormone will suppress the FSH and LH, so it will stop further progression of the puberty. We are giving the GnRH and it is not pulsatile, continuous.
So the thing is, what happens is this is a neuroendocrine hormone. Actually, the GnRH is secreted from the GnRH pulse generator. When you are telling the new GnRH pulse generator, actually this pulse generator is not situated in a single place. It is distributed over different areas of the hypothalamus. We know that there are many areas, the arcuate nucleus, the median eminence. So there are some groups of neurons in all these spaces, and this neural network, the neural network is interconnected, and the interactive action of this produces the pulses, and these pulses get secreted into the portal system of the pituitary, and that is one which produces the cascading of these hormones. So if you are giving a depot preparation of the same GnRH so that it is slowly released into the blood, all the time. That will inhibit the pulses from the GnRH pulse generator. Okay, that is how it acts. Okay, now tell me about the dose and duration.
Dose is 3.75 mg monthly injection, or if it's leprolidestate, 3.7 mg IM monthly injection, or 11.25 3 monthly injection. And
Yes, this is enough for children who are less than 30 kg or so, and we may have to give the double dose for children who are older. Okay, how will we follow up?
follow-up will assess the height, weight, and any further pubertal changes, SMR staging.
Very good. So height, what will happen to the height? Will the growth be abolished, or
there will be a slow growth velocity will be slow when compared to.
Correct,
No?
because the child will be growing in the age appropriate velocity. The spike will be halted. Okay, and maybe a little lesser than that also. Definitely not more than that. Okay, and the pubertal development will get halted. Okay, sometimes the breast may regress, and the pubic hair usually may stay but won't increase. Okay, that is what we observe usually. And how long we should give?
Till the epiphyseal closure, or usually the normal onset of puberty, like around 14 years.
Normal age, around. Sometimes, most of the time, I think we stop at 12 years or so, most of the time, because it's a costly drug and injections and all. Okay, like that it goes. And this has been in use for more than 40 years now, and there are no much of complications, long-term complications like infertility or anything which has been reported. And on stopping the drug, usually within a period of 1 to 1.5 years, the menarche, the periods will occur. That is what literature says. Okay. So have you started in your child?
2 injections were given. Till now,
Okay.
2 monthly injections were given.
Okay. And if we are following up this child and we are finding that the child is not having enough suppression, can we do any blood test so that we can see whether there is biochemical?
We can do LH and FSH again.
We can do actually FSH doesn't have much importance in this because we have already discussed that. We can do an LH after around 3 hours of giving the injection, giving the depot injection, because every depot injection has a small part of aqueous preparation along with it. So there will be an acute spike which is occurring, and you can see the LH. So in that case, the LH should be less than 3 international units per ml. If it is so, if it is less than 3, that means it is acting, and we can continue with the same dose. Okay. Then Vijaykumar sir, anything more? Or?
Nothing to add.
Okay.
Nice.
With the first,
Suppose it is a
Kanata,
hypothalamic
Aditya.
hamartoma, Akshaya, then what will you do? Will you do surgery?
Surgical is the main step of treatment. First.
Yes, sir is specifically asking in case of hypothalamic hamartoma. See, if there is other lesions, definitely, if there is a lesion in the brain, you have to remove it. There is no other question. But this is actually a developmental abnormality. It is a hamartoma. So is it needed? Surgery is needed for all cases?
I don't know, sir.
Okay. Usually, if it is sessile, we don't do. if pedangulated, sometimes they do, because we can just continue with the drug and suppress the puberty. Okay, because it is not a tumor or anything. Okay.
Yes, sir. The cases of hypothalamic hamartoma we have seen all are males. Females, is it rare?
ഫീമെയില് ഞാൻ ഒരു കുട്ടി കണ്ടിട്ടുണ്ട് സാറേ, ഫീമെയില്. സാറ് പറഞ്ഞത് ഇപ്പൊ ഞാൻ ഓർക്കുന്നു, 2-3 പിള്ളേർ മെയിലുണ്ട്. ശരിയാണ്. അങ്ങനെ വായിച്ചിട്ടില്ല സാറേ എന്തെങ്കിലും.
About the, you said it is already localized, enough experience is there. So, is there any affection on the reproductive and the menstrual and the menopause and all when you are following up? And what about the fertility? What about the children affected in this case? How that is affecting the normal endocrinological milieu?
സാറേ ഇപ്പം actually there is literature of more than 35-40 years, and there is no such things have been reported. That is what is being used now also. Ajit sir.
Okay, Riaz, it was a really wonderful experience for me too, and I hope that all the postgraduates who had attended, as well as the pediatricians who had attended, would have gained a lot of insights into how to deal with the case of precocious puberty. And it was really a comprehensive discussion, Dr. Riaz. Thank you very, very much. And also
We should also thank Akshaya and their mentors.
Akshaya
She was excellent. She was excellent.
Also,
she had answers for almost all questions.
I think he was well mentored by Dr. Rajesh, my dear friend, and also a lot of points came from our pioneer endocrinologist, Dr. Vijay Kumar. So thank you, Riaz. And I would just one point, because I happen to see few cases like those children who have a development delay or regression of milestones, all the pages, have a lookout for precocious puberty, because sometimes these children who are having precocious puberty may be a victim of child abuse also. So always be aware of that. And
that is a very important point.
Yeah.
Actually, Ajit, whenever a child with development delay comes with thelarchy, it may not be premature thelarchy at all. It may be precocious puberty. That is very, very important point.
So,
actually, we should teach, sir. We should teach the parents regarding the normal age of occurring these events. Many of them don't know. Sometimes children are brought after menarche has happened, because they don't know. There is breast development. So they don't know
that's a very important point. I think Riaz, IAP can take up make it a card, like just like developmental this one, no, like male precaution 9 years, 8 years, and what is delayed. So some few tips, just like in some of the school or whatever growth charts, or even we have the NHM, we have that book, no, we have that mother and child protection card. Actually, it's a MCP card. I think we can include this precocious and delayed puberty there also in our MCP card also. I think that might be useful. What's the age and what are the things? I think our Jose sir can take it up, and we can make it what you call state level mission to identify precocious puberty early, so that we can introduce drugs which can delay the puberty, so the child can be normal. So thank you very much, Dr. Riaz, my dear friend, and also my dear colleague and friend, Dr. Rajesh and Vijay Kumar. And I hope all the participants would be wiser now. So thank you once again. Vishnu is there. Vishnu, can you?
Yes, sir. So thank you very much, dear Riaz sir, Rajesh sir, and Akshaya for that wonderful session. We all thoroughly enjoyed it, and I'm sure everyone would have enjoyed it, and would be very useful for their further preparations for their exams for all postgraduates. And big thanks to Purushottam sir, Darli madam, and Vijay Kumar sir and all senior faculty members and our dear teacher. We see Purushottam sir and Dali madam's face on all Thursdays, and they both of them stay throughout the presentation on every week. So thank you very much, dear all, for being with us today. That's it. Good night. Shall I end with Purushottam sir and Rajesh sir?
Good night. Okay. Bye.
Thank you.
Good night. Good night. Good night.
Good night, everyone.
Good night.